Thank you, respected persons and my dear friends and respected seniors. And let me at the outset thank Dr. Vijayakumar, my good friend, for asking me to come over here and share my thoughts regarding the basal insulin. And again, he ordered me not to take more than 15 minutes. So let me see, and that made my job easy. And here we are all using the basal insulin for the last 20 years or so. Still, I remember my professor, Dr. R.K. Dash, telling us during my DM days that don't use premix insulin left and right. Start the patient on NPH. At that time, I am very much surprised because during my MBBS and MD, I am trained to use premix insulin in most of the patients. And again, I see my students coming out to me and ask two questions. When to start insulin in a particular diabetic patient? And the second thing is what insulin to start. So before that, I am taking some of the slides from the famous landmark trial led by our great Dr. A.K. Das. This is a real world data from approximately 369 sites from India, where they found that approximately 4 out of 5 people with type 2 diabetes mellitus are uncontrolled. And despite bad control, the average hemoglobin A1C at which insulin is initiated in our country is at 9.2%. And less than 1 in 4 Indians with these blood glucose are on insulin. So they also found that if they are started on insulin, you can see that the hemoglobin A1C reduction is tremendous to the tune of 1%, whereas increasing the dose of OADs is only 0.5%. So when you decide to start insulin, which insulin is better? So already in the previous discussions they said basal insulin is better, whether it is because of uniformity or because to reduce the incidence of hypoglycemia. So why basal insulin first? Yes, this is probably we want to fix fasting first. Why? Because we know that in the Asian data we found that as far as the hemoglobin A1C is concerned, with increasing levels of hemoglobin A1C, the contribution of fasting plasma glucose to the glucose load is more than 61%. That's why you fix fasting, then probably we will have good control of hemoglobin A1C and the glycemic burden in the patient. Here, these are the glucose excretions, what you can see with an elevated fasting hyperglycemia, and we add basal insulin and bring down the fasting plasma glucose, then whole of the glucose burden comes down, and you can see here that the postprandial excursion from a level of 130 milligram per deciliter and comes down to approximately 30 to 50 milligram per deciliter. So here, by simply bringing down the fasting, we are lowering the entire 24-hour glucose profile, the whole glucose burden in the patient. So fix fasting first. Then how this fixing fasting would help in the holistic control of blood glucose? You can see here in the same landmark trial that this control of fasting would lead to hemoglobin A1C reduction of approximately 1%. And of course, both fasting as well as postprandial has gone down by good amount. And this was also shown in other studies where starting the patient on insulin glargine has resulted in not only reduction in the hemoglobin A1C, but it also resulted in reduction in the fasting plasma glucose, thus improving the whole glycemic burden in the individual. And it was shown also that glargine is one of the best basal insulins. Before that, we are using NPH, and some of the persons commented that PJ is the one which uses the maximum amount of NPH at that time, but at that time basal was not available. So the true basal, what the chairperson Dr. Vijay was mentioning regarding the uniformity with some amount of more or less peakless, I don't say peakless, but more or less peakless insulin is the best one to avoid nocturnal hypoglycemia. And you can see all those studies which showed that there is a consistent reduction in the hemoglobin A1C through so many studies and throughout these 2 decades. And when you look at the basal insulin, as most of us are experienced with usage of premix insulin, then whether premix insulin, because this is all our experience, because most of you are very well versed with premix insulin, whether this basal is faring, how it is faring against the premix insulin. This is a beautiful study where they compared this basal insulin against the co-formulation idagaspart, and despite having the similar hemoglobin A1C control, you can see that the fasting is better using a basal insulin alone. And when you look at the uses of our own premixed insulins, not this one analog, there we can see that even the hemoglobin A1C reduction is more, around 25% more when we use only basal insulin, whereas we use premixed insulin, the reduction in the hemoglobin A1C is not that much. What the guidelines say, actually, we had a lot of discussion regarding the guidelines, but I think because of lack of time, sir didn't discuss about the insulin guidelines. But of course, insulin guidelines have come and they said that you have to use basal insulin first, so that we can bring down the fasting and subsequently all other parameters in the glucose control. So when you look at the initial dose to start with, this is what most of the general practitioners have a doubt. So it is easiest to say that you start the basal insulin at a dose of 10 units. Most of the times people have a doubt whether to start in the morning or start in the night. Yes, a basal insulin, because of this basal nature, it can be given at any point of time. But yes, most of us are accustomed to give basal insulin in the night time, and it's the best also. So better to give in the night time. And the dose should always, as somebody mentioned, though guidelines say that this is to be the one which we have to start with, but we know that the patient is the most important, and you are the one who knows the patient best, and the dose at which you start is 10 units, but depending upon the other comorbidities, it can be started at a slightly lower dose or higher dose. And then you monitor the fasting first and see the consequently 3 fasting readings. If it is still more than 130 or 150 milligram per deciliter, then increase the dose by approximately 2 units. It is as simple as that. And you titrate. Then if the fasting is coming down to less than 120, then wait and continue the patient on the same dose along with other OADs, and you monitor hemoglobin A1C at 3 months. And the control is good. Yes, it is good. If it is not, then you think about the postprandial control. And you know that this type of treatment is timely effective, and most of the patients are stable for long periods of time and with good uniform glycemic control. And the most other thing, as the previous speaker has mentioned about the hypoglycemia, yes, the hypoglycemia should be low, because to have satisfaction and what you call reliability and the confidence which a practitioner has in treating the patient. And we know that the patient who develops a nocturnal hypoglycemia, especially severe, he never wants to use insulin again, though you teach him or tell him anything. So this is very important to prevent the hypoglycemia in these patients, apart from all those disadvantages sir has mentioned in the previous talk. So this hypoglycemia, when you look at which insulins produce less amount of hypoglycemia, then we know that in comparison with the co-formulation, you know that the rate of hypoglycemia is approximately 86% less with insulin glargine. And when you compare with premixed insulin analog, yes, you can see there that the again hypoglycemia risk is less. If you look at the premixed insulin also, you see that hypoglycemia risk is very less with using basal insulin. And the nocturnal hypoglycemia, which is a dreaded one, yes, of course, that is also less when you are using the basal insulin. Then coming out to the satisfaction. See, the most important, after all, after the patient takes treatment, it is most important that he feels happy about the control, happy about the type of the lifestyle he has. Though our people said eating protein and all those things, but it is very difficult if I reduce my carb intake. Let me see how many of you go there out and eat in the lunch the less amount of carb and more amount of protein. I think unless Jivik has arranged something which is protein in the disguise of carbohydrate. Okay, so when we are looking at the satisfaction scores, it was shown by this study from the China that yes, that satisfaction score is better with basal insulin when compared to premix insulin. So it is an observational study, and this is important, that the satisfaction of the patient is very much important, because it's a chronic therapy and patient has to use insulin for a long period of time. So the answer to the question that which is the ideal insulin to start with is basal over the premix, because of one is uniform glycemic control, the second one is the lower risk of hypoglycemia. So sir, with the present available options, so now the glargine is considered the benchmark of insulin therapy, because most of the other basal insulins, when they came over and the studies, they compared with standard other arm as the glargine as the standard arm, and they compared the efficacy, making the glargine as the standard insulin therapy. And of course, the incidence of hypoglycemia is very less, and it produces a holistic glycemic control, reducing the glycemic burden in the individual, both fasting as well as postprandial to a certain extent. So with this, I think I made myself clear that basal insulins are better when you start insulin in the individuals. So with this, the key takeaways home are: basal insulin is recommended as the most convenient initial insulin regime when the patient is uncontrolled over oral agents, and even at high hemoglobin A1c more than 9.5%, probably glargine 100 is the effective and well tolerated insulin with best quality of life. And over the course of time, this has evolved as a standard insulin, basal insulin, where the other insulins are compared with. And of course, the most important is that it gives lesser amount of hypoglycemia, so the physician can sleep well after writing this insulin. With this, I thank you very much. Thank you for the patient hearing. I think I finished on time.
Thank you, sir, for